Hi, Mike Gibson and the team coming to you virtually from TCT 2020. It's our last wrap up here on day 4, and I'm joined by a superstar team of Mamas, Roxana Mehran and Ajay Kirtane. Exciting day today, guys. Thanks for joining us this afternoon. Several things presented today in the late breakers, a lot of different stent trials. What did all of you think of the Host Polytech ACS? 3,500 patients, lots of different stents. Roxana, what did you take away from it?
I think, this was an acute coronary syndrome patient population. We have to congratulate these incredible investigators to really evaluate biodegradable versus a durable polymer stents. And unfortunately, they didn't show any kind of a benefit amongst the biodegradable polymer. It was really a basket full of different kinds of stents. So they're not all created equal. We know that there are differences, but at the end of the day, I think it just shows you that if you have a really good durable polymer that has been previously shown to be safe, it's difficult to beat the stent thrombosis numbers and the safety numbers. And I think at the end of the day, it looked as if that they both perform well, and the biodegradable polymers don't have an added benefit compared to a durable polymer.
Speaking of polymers, there is the Cobra Reduce, high bleeding risk patients. What did you think, Ajay?
So just for sake of full disclosure, Roxana and I are on the steering committee of the trial, but I would say that what's interesting with this stent platform is that for super high bleeding risk patients, we've tried to minimize the amount of DAP that we have to give patients. And what this study tried to do is to determine at 14 days, was the stent safe with stopping DAP? And it did appear to be safe. Unfortunately, it did not either meet or beat its comparator group, which was DES treated with a more conventional duration of dual antiplatelet therapy. The only thing I would say, though, is that it's a moving bar, because right now we have DES that are approved with a month duration of dual antiplatelet therapy. And for many individuals, that's going to be sufficient. There are some super high risk bleeding patients for whom even a month may be too long, and that may be a niche for this type of stent platform. Certainly those people weren't randomized in this trial because you had to be able to be randomized to the control arm, which would take up to 3 months of DAP. So I think that it's a moving target for sure. I would love to get below a month with a DES. That would be great, but we certainly aren't there yet. I'm just happy with 1 month of dual antiplatelet therapy with current generation DES, which would suffice for most patients.
Mike, I wanted to just add, and again, full disclosure of being on the steering committee of this trial, I just think it's really hard to study this population of patients on oral anticoagulants, which is what was the population that was being studied. And everything that Ajay said is exactly right on. But remember that this trial was being conducted around the time that all these new recommendations were coming out regarding oral anticoagulation and what to do with your dual antiplatelet regimen or single antiplatelet regimen. So I think we have to sort of think about this in that context. And I hope that we don't throw the baby out with the bathwater here, because I still think if there is a possibility to have a shorter duration, it would be great. But obviously, hopefully this company will work on a drug elution, because the ischemia-driven revascularizations were what was different here.
I mean, the other thing let's not forget is that there are now moves towards using drug-eluting balloons as well. I mean, there are a number of trials coming out in this population where premature discontinuation of DAPT wouldn't be such a worry. And the other thing with the Cobra Reduce trial is that the investigators didn't present their use of intravascular imaging, and of course that might impact on the ischemic rates that were reported.
Well, speaking of balloons, when Ajay and Mamas were in high school, I was doing conventional balloon angioplasty, and there's this balloon called the ACE and the probe. They both had just a little wire on the end of them. When you couldn't cross with anything else, you got the ACE out. Now we have a stent, the Svelte stent, a stent on a very low profile balloon with a little wire on the end, tested out in the optimized trial. What did you guys think? Mamas, what did you think of the results?
I mean, from a conceptual perspective, I'm not sure about the utility of such a device. I mean, I've used it, and we used it about 3 or 4 years ago when it came to the UK. And one of the golden rules of angioplasty is don't lose your wire position. And yet, you deploy this stent, you have to take everything out, and you don't have wire position. And very much the move is towards prepare your lesions and optimize your lesions. And when you don't have a wire in place, that's challenging. I think, to me, the interesting aspect of this trial were the endpoints, and we can discuss about the periprocedural MI aspects.
Well, more of a device for a guy like me who's a direct stenting guy. Ajay, is there a need for this kind of device in 2020?
Well, I thought I convinced you out of direct stenting, and we're going to do imaging, we're going to do pre-DIL, we're going to prep properly.
Yeah.
I'm still working. Actually, I was talking to Dwayne Pinto. He said he's been working too, and it's kind of like the 2-hit model of mutations. You need multiple strikes.
Yeah, I got a lot of people hitting me. Yeah.
But no, I think that, look, I'm intrigued by having new tools. I'm not sure where I would use it with the current generation of DES, and also especially the advantage of guide extensions, which has been really, I mean, you don't hear me say game-changing or revolutionary, but that really has changed the practice of PCI.
I have to say, since I have been an interventional cardiologist, it is one of the biggest advances I think I've seen is having guide extensions, definitely. I mean, there's hardly any, there's very few lesions, I mean, that you can't cross now and get a stent into with guide extensions.
So my feeling is that it may have some indication there. Dean Kiriakis mentioned that the stent itself, the platform itself, may have other uses. It comes in a monorail version, I believe, as well. So I think that's good. Let's not forget, though, the trial did miss its primary endpoint. There were reanalyses done, and I think for me, besides the technology and the fact that it would be cool to have it, the biggest take home from this, and this is not just this trial, this comes on a series of other trials, is that just routine ascertainment of biomarkers, and in this case, troponins, which were rated as MIs if they were just above the upper limit of normal, just throws so much noise into the picture that it becomes hard to discern differences between devices with that much noise that's not impacted by the device choice.
Well, Ajay, particularly when you're using as a comparator, historical comparator, trials that use CKMB. I mean, that's like saying we're going to compare these apples to these oranges 5 years ago. That just makes no sense. So the regulatory science has to evolve, which brings me to the late breaking science today. And what I thought was really, really important was all the debate about periprocedural MI, which is exactly what you're getting at, Ajay. And we really have a lot of work to do in defining periprocedural MI. Roxana, you paid close attention to the session. Tell us what you learned.
I mean, I think, it's really hard when you're starting to, I think when we're designing studies, we are now in interventional cardiology reaching in the 2,000, 3,000, 4,000 because the numbers of events on those hard endpoints have really, really come down. The spontaneous MI rates are really small. Stent thrombosis is under 1% in the, and if you just count death MI, CVA, it's really like you're basically in a couple of percentiles. And so if you're not, and the reason I think it's been going on in this way, and I'm seeing, I see some of the pharma trials. I mean, I'm looking at the Atlantic trial, for example. They basically took all of the MIs, and I think it's, we do need to get a little bit more closer attention to the MIs that matter. I know that that you personally and all of us, nobody wants an enzyme elevation, but I'm not so sure what it really means when it doesn't have a clinical implication. We know that there is a threshold value for which there is an important prognostic impact of periprocedural myocardial infarction, especially when there's something happening in the procedure, and that should absolutely be counted. But any troponin elevation, that becomes really crazy.
I think one of the things that there are two things I'd make really quick, is that the FDA is really interested in safety. They want to make sure that a device does not have an adverse safety profile. And I think that's one of the reasons why they'd like to see routine enzyme ascertainments, because you might not pick up things if you don't actually look. The challenge that we have now is that we don't ever measure these in clinical practice if there's no sequelae, and we often send people home at 6 hours. So you're trying to, make an artificial clinical process that doesn't actually exist. The second thing is that many people who design clinical trials know that if you have a higher event rate, typically sample size goes down. The problem is if your endpoint that's introduced to raise the event rate is just noise and is not differentially impacted by the treatment you're studying, actually it has the reverse effect, and your sample size necessary to show a difference goes up. And I think that's a really important point that people don't often understand, even if they understand the concept of increasing event rates, lower sample size.
And let's not forget the vast majority of peri-procedural MIs in this study, they went home the following day. And in my view, you know, to have an endpoint that's relevant is one that has a prognostic impact. And a small troponin rise of, you know, 3-4 greater than the upper limit of normal, you know, it's just not relevant.
Well, it may be relevant, but we just don't have, it may be relevant, but at a modest rate. I think we have some studies from Duke and others that show in very, very large sample sizes, yes, there is an uptick in mortality, but it's not, it's modest. So it would have a modest impact, I guess. And then also there was, I thought, some hot stuff on the mitral clip in STEMI. Roxana, you really like this one. Tell us a little bit about it.
Well, this one was very interesting. It was, you know, and we all know that when a STEMI is complicated by mitral regurgitation and torrential mitral regurgitation, we're sending these patients to the operating room, and they don't do very well. This is something we get very worried about, especially when there's papillary muscle rupture or dysfunction. And in here, what they did is perform mitral clip on patients with mitral regurgitation complicated by a STEMI, you know, and really they got pretty good results given that these are really high risk patients. And so I was impressed with this study overall.
Mamas, what do you think?
I mean, it was impressive, but it was a highly selected population. I mean, a 10% mortality in those with cardiogenic shock undergoing these procedures, you know, it implies to me it's incredibly selective. But, you know, in the selected patients in which the procedure was undertaken, the results were good, and it's interesting.
Ajay?
Yeah, I think the paradigm for me at least has changed in the sense that we typically do involve the surgeons, but we call the structural team as well. And, you know, sick patient with acute MR with a STEMI, the surgeons really don't want to operate on these patients. If they want to, I think it's reasonable, but the mortality is so high that if it's clippable by a good team, then we often default to that approach first. And I think this kind of parallels the outcomes that many that have done this have seen, but it's nice to see it amalgamated with a larger series of patients. So it's not just this one-off thing that people talk about and then they do. And that's important for everything we're talking about. We're not making recommendations for any of this stuff. We're just sort of analyzing the data and giving our opinions. The same thing is true with the DAP. We're not saying people should get 2 weeks or a month of DAP. We're saying these are what the data showed among the patients who were treated.
Some additional structural heart data today from partners, the valve data with some longer term follow-up. Roxana, what do you think there?
You know, 5-year follow-up of valve-in-valve. I was struck by this huge mortality in these patients at 5 years. Over 50% of these patients are dead. So these are pretty high-risk patients, but for those who remained alive, I was impressed that the hemodynamics seemed to stay quite good, and that the durability of the valve in valve was quite good in those who were still alive. So it was quite you know, incredible work by the investigators to follow everyone out to 5 years. And I think for sure we need more and more evidence in this patient population and with different kinds of valves, because, you know, as we're watching, understanding the valve orifice when you're going in with a balloon expandable versus a self-expanding valve, the kinds of hemodynamics that you might get in a valve-in-valve would be very interesting to evaluate down the line with different valve platforms.
Ajay, any thoughts?
No, I just want to commend the investigators not only for presenting longer term follow-up data, but also extending follow-up for some of these patients that are in the valve trials, because it seems like such an amazing technology when you look at the shorter term outcomes, but we need to understand more the natural history of these patients and how they respond to the therapies we administer. And that really should be the paradigm for what we do in device trials, because it so often falls by the wayside to follow these people for longer.
I mean, to me, the most impressive thing was that their 5-year outcomes are very similar to the native intermediate risk patients, almost identical stroke rates to almost identical mortality rates in these patients. So it's really interesting to see that actually these valve-in-valve patients have relatively good outcomes, you could say.
Mm-hmm. All right, so to close up, let's ask everyone, what did you think was the most important contribution in terms of trials or late-breaking science from this meeting? Mamas, what was it for you?
I mean, it's difficult. I mean, for me, I thought one of the interesting things was around probably this whole discussion around myocardial infarction. I think that's really quite important. I think Roxana's trial was very important as well. The largest HBR trial to date, 3,500 patients. It helps us think about optimal antiplatelet duration in these high bleeding risk patients. Some really great data in this population.
Roxana, what did you think?
Look, I mean, I think, first of all, we were thrilled that in this very, very difficult year with COVID, that the investigators worked really, really hard, as did the coordinators for all of these trials, to bring the trials to the finish line, and as well as data coordinating centers that worked around the clock to actually bring science to TCT. So as a whole, obviously, we're just so thrilled to see some of these important studies come. I mean, look, we learned a lot about physiology during this meeting, understanding, and what was wonderful is imaging and physiology was very, very important in this meeting. And we saw that our live cases were also very much centered around optimizing your efforts. And I think this is what Ajay showed everyone on that first day. We learned about the vulnerable plaque on that first day, and then we moved on to the HBR patients. And today was a big HBR session. And I think we also were very lucky to see some of the first trials on stent versus valve studies, and that's not happened before. We were on the structural side. We learned a lot, and I think that it tells us that our field continues to thrive on working in the questions we need to answer, and we continue to be driven by evidence-based medicine. And of course, we look forward to the more and more of the trials coming to TCT, but I was impressed by the diverse inclusion of so many trials. Now, tomorrow, we have a whole day and sessions around endovascular. To be very honest, I was absolutely blown away with some of those trials, with longer term follow-ups on the paclitaxel eluting balloons, as well as the Voyager, some of the sub-analyses from the largest Voyager study. So there is just it's been a potpourri of the most interesting, and for me, it's been great to actually start to see some new data and to talk about new things, and TCT is always refreshing in that way.
Ajay, how about you?
Yeah, I mean, I couldn't agree more with what Roxana said. For me, just the ability to talk about new things that was different from not just COVID, but the day-to-day. So it's been so tough for everybody because it's like the same week every week, and many of us are used to interacting with colleagues and collaborating, and that sort of thing has gone away. And so just to be able to do that, even in a virtual sense, was incredible. And I just want to thank everybody for submitting trials and getting things done under deadlines that were hard to do because of COVID. So for us, that was really great. The endovascular sessions tomorrow are going to be also really great. And it's something that Sahil Parikh in particular has worked very, very hard to get at TCT. And we feel pretty proud of what's going to be presented tomorrow. The one other thing I just wanted to make sure people know also, there's a special fellows session, 2 fellow sessions that are case reviews. That'll be 2-hour case reviews. We've actually posted the stems of the cases. So what we're going to be presenting online already at medshare.com. And you can look at what we're going to present, and then there'll be an open panel discussion with chatting from fellows. And we hope to bring across some basic educational points, because I really feel that in this year, they have probably suffered more than any of the rest of us in terms of this knowledge gap and teaching gap. So that's going to be great. There are also some other lectures and sponsored sessions around that. But overall, I know this is our last wrap up. I just want to thank everybody for just tuning in. We've had so many wonderful direct messages and texts from people saying that this actually made a difference to them, and in a great way. I was only hoping for a little bit, but in a great way for many people. And for that, it just is really heartwarming. And all the kudos goes to the CRF staff who did such a great job under duress to be able to get this done. So thanks, everybody.
Absolutely. And, Ajay, I felt a little bit like I was back in the 90s when there was so much excitement, a lot of it surrounding physiology and imaging. It felt like we were really evaluating the underlying biology here more, which I thought was really great to kind of not just this and that device, but the physiology was so great to see. For me, I know you guys are going to laugh maybe, but I thought Prospect was quite important for me because it really said when you put the constituents of the wall in the model, the plaque volume, and when you put in the plaque constituency, the amount of lipid, now you can play a lot with multivariate models, but it beat out the minimal lumen area. So we fixed lumens, but what this said to me is there's a lot going on in the wall. And, I don't know, I'm hopeful, we'll continue to learn more about the wall and that we'll have some therapies that focus on the wall, rather than just on the lumen. Of course, the
We're
lumen
missing
is
the
quite
Nears
important.
wall.
What's that?
We're missing the Nears wall today.
I know. Mamas
Yeah,
has
we're
figured it
missing-
out. He took care of the
Stop
lipid.
the presses. But you know what I'm saying? I mean, there were some great technologies where you were going to put some, phytochemicals into the wall and then laser ablate the wall and get rid of diffuse plaques.
I
So,
know you're working on a trial that's going to help the wall.
well, we
You're
hope.
working on efflux.
Yeah, we're
and
working on cholesterol efflux,
Yeah.
trying
That's going to help
to,
the wall, right? You're vacuuming the wall, aren't you?
yeah, that's why I want to work on the wall. We focus on the whole of the donut. I'm trying to work on the donut. So it was good to see some work on the donut. It was good to see some good old physiology of blood flow. I thought it was all great, but
You gotta think in interventional cardiology. Too many people think with their hands, and this meeting was a little bit more about not just the hands, but the brain and how you
right,
assess what's going on.
right.
Yeah.
Cardiology interested in the wall as well as President Trump.
Yes. Well, I got to say, it was great. The virtual thing was great, but you just don't have the hallway conversations. And
Yeah.
I miss all my friends. I miss you guys. It's great seeing you virtually. I give you big virtual hugs, but it's just not the same.
It's not the same.
It's not the same as giving Roxana a great big hug, So, hopefully we'll be back face to face soon. But I really got to compliment you, Ajay, Juan, Marty, the entire CRF team for a great virtual meeting this year.
I mean, TCT is known as an international meeting. I just feel this year with the virtual format, we've just had so many more international faculty that have been able to get involved than would have been able, economically or to have time off work to actually fly to the US. So, I think the team have done an absolutely fantastic job in really making this an even more global meeting than it has been in the past. It's amazing.
No, thanks. We do feel bad. We do feel bad though. There's a lot of loyal faculty who've been part of TCT for a long time who, because we had to truncate the sessions, couldn't necessarily contribute. And we did send notes to them, a note to all of them, but we sincerely feel it because this is a global effort. It's a world effort, and it's not an effort of a few people, because if it's only a few people, then it dies. Whereas I think if it's a world effort, then it continues to thrive.
I mean, we really miss them, don't we? I mean, we had to come to a shortened version of TCT that would be manageable in this terrible situation that everyone is going through, but yet we'd be able to educate everyone. And so we had to we usually have 1,400 faculty. We were down to 400 plus faculty. That was a huge loss for many of us, not having those 1,000 voices heard. And we want, we know that they're loyal to us and that we will work very, very closely with them and include them in multitudes of other venues as we go forward throughout the year. And we look forward to absolutely having them be very present next year. Hopefully we can be in person next year. We can only pray.
And the social media team have done a fantastic job. So 64 people have been tweeting all the time. I mean, I think they've really brought the meeting alive and really helped in knowledge dissemination. I mean, I've been so impressed by the amount of time that people have just been on, engaging, tweeting. It's been incredible. So thank you to all the team as well.
What about this TCTMD team, Mike?
Yeah.
Don't you love them? I mean, they are just amazing. Not only the reporting has been incredible.
Oh yeah, always.
Stephanie
Yes.
is such an incredible leader. And
Shelley as well.
I think we've been so lucky, and of course Shelley and her team reporting, but reporting on everything in a very transparent way. Whether it's they're really we don't CRF doesn't have any influence on what our reporters do. The reporters are extremely free and they do such great work, and I love that they are fierce and they get to the bottom of the story, and they're extremely transparent. So that's been a great way. But you, Mike,
well, very global.
Thank you, Mike, for your incredible. You bring us all together. You're such a leader, and thank you for not only tweeting about TCT, your beautiful artwork, especially today, and also your wonderful updates on what's going on in the health of America. So thank you for everything that you do every day.
Well, I also want to give a shout out again to Shelley. I do think Shelley Wood is probably one of the best medical journalists out there. We're lucky to have her in cardiovascular disease, but she's very talented, very good. And I also think this was a great first step into the virtual side of things. Ajay, I hope in years to come, even if we are face-to-face again, we can still bring all the content virtually to everyone around the world. But for those of us who can make it and want to do the face-to-face kind of interactions that we all love so much, we can do that. So hopefully there'll be something for everybody in the future. I think this is a great step to make that hybrid model happen, right?
Couldn't agree more. And Stephanie and the team has already been thinking about it. We've done it in the years past too. Like unlike other meetings that restrict, pictures and that sort of thing, we've not done that, as you know. So we can only go up, and we'll learn a lot from this as well going forward. But thanks to everybody once again.
And I'm so, your NIRS infrared painting, where did it go, mamas? I mean, I was so inspired by that. I mean, I was just thinking about
it turned into a cappuccino.
The wall is your next painting.
I need to paint you something for your wall. I mean, that's too monochromatic there. You need some more color again.
That's your next painting subject, the wall.
All right, well, guys, it's just so great. My favorite thing is always my time I spend with you guys, and love all of you. Thanks for joining us, mamas, and thanks to everybody for joining us here, at least virtually, from TCT 2020.